All right. Excellent music. Thank you for turning that off. And welcome, everybody, to the 2024 CDC Guidelines to prevent transmission of pathogens in healthcare settings. And what this is going to be a conversation among a group of experts to discuss the implications and the specifics of this really remarkable change. You can see our learning objectives there to recognize the stethoscope hygiene importance, the changes in the guidelines, to understand what the implications are, and to know the consequences. We're going to have a lot of our reviewers weigh in, and I'm going to introduce them now. We have a group of them from all over the House of Medicine, and I'll start with Kathleen Vollman. She's an expert in critical care implementation and compliance, a nurse who knows what she's talking about in this area. Francesca Torriani, who is an infectious disease physician, an expert in infection control protocols and implementation. Then Cynthia Cadwell, who is also an RN, expert in quality and patient safety, runs around consulting around this. Stuart Kipper is an expert in auscultation, hygiene, and advocate. And you will also notice that he is in some of the video that comes later. He has been a huge advocate of this for a long time. Steve Wehrman is a respiratory therapist, another group in the House of Medicine that has strong interactions with the stethoscope. And finally, Alpesh Amin, who is a hospitalist, expert in hospital medicine, the chairman of his department, and he has published some of the seminal work in stethoscope hygiene as early as 2015. So you've seen the objectives, and now we'll start with the actual topic. All right. So if you look at the CDC guidelines, you'll see that's a draft of the 2024 guidelines. They're not officially released, but we're going to talk about it because the changes that are proposed are critical and significant. If you read them, this is an update to the 2007 guideline. What in medicine takes that many years? It's 2024 to get updated, but that's the reality. And in those guidelines, they said that the stethoscope was not a critical piece of equipment, and that it is should be washed weekly unless it was visibly soiled. And that's the most absurd thing I have ever heard, because I don't have microscopic vision. So how would I know that I've got Candida auris, the fungus that will kill you if you get it on you? Because we don't have an antibiotic for it. And that's the reality. So these guidelines were far overdue to be updated. You can see what's going on in the video there. It's pretty impressive when you see it as if you had microscopic vision. What the new guidelines say is they recognize that touch is the spread of disease and that we shouldn't be touching patients with dirty stuff. The stethoscope is now considered a potential contaminant. This is brand new in the guidelines. And that you may use disposable equipment to minimize cross-contamination. Some of the point we'll have today is that disposable equipment can be the cover for your diaphragm of your stethoscope so that there never has to be a dirty stethoscope touching a patient again. Okay. So let me start by asking some questions of our cohort here. Stuart, Kipper, what's the most meaningful for you about these changes and the guidelines and your patient care?
Well, it seems like they're finally being paid attention to, as you mentioned, Frank, was far back as 2007. I came from graduate school, worked in a lab, everything was sterile, everything had to be precise, and we couldn't contaminate our work for fear of not being able to publish. I went on to med school and realized that there were a lot of moments in the practice of medicine that did not involve professionals ourselves taking enough care to prevent the spread of disease. I mean, with people's ties dipped into patients. I never, ever saw anybody clean the stethoscope. And with respect to the nurses who were on our panel, I did see nurses do it, but not as often as I would have liked. Ultimately, it became clear that cleaning my stethoscope between every patient was a pain in the neck. I tried very hard to do it. But even for me, and I was well aware of these problems, it was time consuming and a pain. I ran into the people who had some ideas at Aseptoscope, and it became clear that this was an easy and effective way for us to provide safety for that very intimate tool we all use. So.
Yeah, I've never seen a doctor without a stethoscope. People say that they can use the ultrasound machine now, but you can't tell if someone's wheezing with the ultrasound machine. I can't figure out when.
So it's also heavy to carry around your neck, an ultrasound machine.
Exactly. Hey, Alpesh, you published in 2015 the third hand. I don't think most people understand what the third hand is. Can you talk to that a bit?
Yeah, thanks, Frank. So, the third hand was a way to get people's attention to say, hey, you got your hands, which both hands have to, and we've talked a lot about hand hygiene, but if, as you and Stuart just mentioned, people are walking around with stethoscopes, doctors, nurses, trainees, respiratory therapists, everybody's walking around with the stethoscope. So it was to get people's attention that the third hand actually is the stethoscope, and the stethoscope carries bugs from point to point, just like you mentioned, just like the hands do. And I think as we've learned about this over the years, the research has shown that the same bugs that are on your hands are on your stethoscope and going from patient to patient, which is not a good thing. In the article that you referenced back in 2015, it was actually the reason we did the article, the study the way we did was because there was a fair number of reports prior to that showed that there was pretty poor stethoscope hygiene in the past, but none was really truly observed. So even though our study was limited with only 352 observations, it was all observed patients. And what we found was the same thing, that only about 58 of those encounters actually had some sort of stethoscope hygiene done, whether it was cleaning with an alcohol pad or whatever was used. So that was only about 16%. That was a really low number, and it was similar to the rest of what the literature had reported. But these were now observed encounters. But then when we drilled into it even more, what we found was that more than 80% of the ones that were cleaned were in isolated patients. But when you took the non-isolated patients, which is the greater majority of the patients that we have in the hospital, it was less than 4% of patients that had stethoscope hygiene. And so in order for us to kind of raise the platform on this and raise the attention, we called it the third hand as a way of getting folks to understand that this was really important. I'll make one last point, Frank, is that one of the things that we also learned from this study is that folks can, like attendings, can actually role model. And when they role model the use of whether it's a barrier device or a cleaning entity like alcohol, trainees and others would follow suit. So, so this becomes a really important point also that came out in that study.
Absolutely. And that speaks to the next part of this, which is, it's difficult to get practitioners, nurses and doctors and RTs and everybody else to change their habits. Can you comment on that, integrating hygiene requirements into complete infection control strategy?
Yeah, thanks, Frank. You've got to make it easy for people to do the right thing. And a perfect example of this was we didn't clean the ports on IVs. They were supposed to be cleaned every time with alcohol, very much like a stethoscope every time you use it. And that didn't happen. So technology came in and put a cap on that had alcohol in it in order to force function the behavior. And I really see technology playing a huge role in our ability to successfully do this and integrate it, because it's critical that this moved into the category of transmission via touch. And so it will raise the level because it's now considered a significant vector in transmission for infection. And so we've got to be able to make it easy, again, for people to do the right thing.
Yeah, that's really sort of critical. I think we have another question coming up here, which is how prepared are we to protect patients from the now recognized challenge of stethoscope hygiene needs for transmission via touch, that we can spread bugs around by touching like we do with our hands, but our stethoscopes are the same animal. So Francesca, you're an infectious disease doctor. Can you can give us some commentary on protocolizing and implementing compliance tracking and how that will either help or hurt?
So I think what's important is to integrate it into other things that we have automated, right? Like hand hygiene. When you enter a room with a patient or before you touch that patient or you interact with that patient, you will be doing hand hygiene. And I think that the main challenge and the main idea we came up with was that if you put it at the same, if you put the stethoscope, the protector at the same site of hand hygiene, then people will also do that, will start automating that. And so you have to make it accessible to each patient room before entering the room. And in most institutions, whether these are outpatient institutions or DED or elsewhere or inpatient, that alcohol gel right there will be right there upon entering the room.
Foam in, foam out. I have hand washing police that watch me, and if I don't do it, I get a bad boy check. And I don't want to have too many bad boy checks, or my chairman comes and talks to me. Hey, Steve, you know, we need to get some respiratory therapies perspective here. 60 seconds of rubbing alcohol on the stethoscope is the recommended thing to do. Even then, it leaves about 28% of the diaphragms still having pathogens on them. But that was the old recommendations. How possible is that in your practice?
Thanks, Frank. Actually, it's not. I just did a quick calculation. For a critical care respiratory therapist, a 60-second cleaning between patients would lose an hour of productive time per shift. And it's not that we don't want to do it, it's that nobody can do that. And then in the end, your stethoscope would still have alcohol-resistant germs on it. So the current method, it's well-meaning, but it's simply not workable in any type of acute care setting like that. It's not practical.
Yeah, I don't, you know, I have to wash my hands probably 50 times a day when I'm working in the ER, you know, before and after every patient. I don't know how I can spend another minute washing my stethoscope in a proper fashion, because I just don't see it going to get done. Cindy, you know, we finally got data that we got disposable. The recommendations include the possibility of disposable stethoscope. What do you think about that?
Oh, Frank, I'm so glad you asked that. First of all, I'd just like to concur with everything that I've heard so far. I've had that very virtual experience. We need to make it easy. We need to make it accessible, and we need to make it within the workflow. One of those things is not the disposable stethoscope. I had the experience during COVID to work inside a facility, a skilled nursing facility, where no other people were coming in, let alone additional equipment. And without the use of a good stethoscope that worked, I would not have been able to make differential diagnoses at all. And the thought of using these disposable stethoscopes that you really can't use for good definitive diagnoses, let alone that other people are using in and out of their ears, is just not something that is particularly of interest to any good healthcare professional. So having the ability to come in, wash your hands, put on gloves, and then have basically the ability to put on a glove to your stethoscope and actually discern the sounds that you're looking for is really, really important. And I just can't emphasize enough how important that is. And so it's really about time that we have the technology that supports our ability to truly diagnose patients and protect them.
Yeah, and that's a critical point. Not only is the disposable stethoscope a toy, I mean, you can get them at Toys R Us. My 5-year-old has one. They are also spreading bugs between providers. When they've been cultured in large trials, about 5% of them have Pseudomonas on them that they got from somebody else's ear. And I like you guys, but I don't want your Pseudomonas in my ears. I don't share stethoscopes. When people ask me, "Can I use your stethoscope?" I go, "No,
No.
it's just a different animal." All righty. So at this point, we're going to move on to the next set of questions. It's stethoscope barriers have been proposed for use in breaking the transmission. And you can see this video of how they do it. So you just wave your hand under there. It takes all of 2 seconds, and now you've got an aseptic contact. The dirty stethoscope never has to touch the patient again. And so the idea is that this would replace certainly the disposable stethoscope, but also the need for washing your stethoscope for 60 seconds between every one. We have data on the University of California, San Diego study that demonstrates that these are effective. So what this study did was we took a bunch of stethoscopes and we smeared stool and infected urine and pus. And, you got to have a friend who's an infectious disease doctor to do this, because most people don't have a freezer full of this stuff, but they do. And then we randomized stethoscopes to either having a barrier on them or not, and into the incubator they went. And then 15 minutes later, half an hour, a few hours later, we pulled them out and cultured them. We did that for a week. Every single culture with a barrier was sterile. Every single culture without a barrier had something terrible on it, like ESBWL or crab or MRSA, or all the nasty bugs you really don't want to have on you. And so what it's demonstrated clearly and unambiguously, it's a sterile contact. The proper term is aseptic. It is an aseptic contact. So that's the improvement that we've done. If we could go on to the next slide, Stuart, you were involved in this trial. This was the user acceptance trial. You want to talk about it a little?
Sure. So having looked for a faster, smarter way to clean my stethoscope, I was happy to participate in this. We had some machinery mounted on our walls in each of my exam rooms, and proceeded to begin using the stethoscope barrier. As you can see, I'm using it in front of a patient. I wave my hand or my stethoscope underneath the activating device, and out comes a patch. Every patient I ever did this with, from the beginning of the study until currently, because I now use them routinely in my office and will never go back to cleaning my stethoscope poorly with alcohol, looks at what I'm doing. Most of my patients now know what it's about, but my new patients are always fascinated. They're always interested. It bonds me to them. They think I'm doing a great job, and why aren't all their other doctors doing this? And what's wrong with that? I try to stay above that fray and say they'll be coming around, not to worry. But the study just presented on all fronts the ease of use, the benefit to the patient, and the way in which our patients felt much more confident in us that we were taking their health seriously. And it saved me, as as was said earlier, it saved me a lot of time. And I used to sit there and clean my stethoscope while I'm talking to the patient, never feeling I was doing a great job. I always thought I was moving all the bugs to the edge of the stethoscope. And yet I was always putting the edge of the stethoscope on my patients. That said, the study, it was fun to participate, and proved that it works and it's easy. And I can't imagine anybody not using this method of stethoscope hygiene going forward.
Yeah, I think that's really important. Kathleen earlier said.
And just to highlight what Cindy said earlier about toy stethoscopes, etc. My stethoscope is an extension of my ability to practice medicine. I'm not picking a toy up off the shelf every time I examine someone. So.
I think that's a really important point. The other thing that you alluded to was the same thing that Kathleen said, was you have to make it easy to do the right thing. And if it's easy to do it, people will do it. And this point of that study was that 90% of people thought it was easier to do this than the other way. The other thing is that you alluded to is patients now clearly understand that there's a barrier, and there's a study that's been recently accepted for publication at the Cleveland Clinic where they had patients look at this and decide what they thought, and they felt that was a superior aspect as well. So it's a clear message to your patient that you're working for them, and your patients develop, some sense of that what you're doing is working. So it's moving in the right direction. So the next slide is about the acoustic functionality of the barrier. If the barrier stops bugs, but it makes the stethoscope a toy, there's no point in it. This is a study done by Sarathi Kalra, who is one of my old residents who grew up to be a full-on kicking attending. He did a trial looking at 800 interaction between a physician and a simulation mannequin. The advantage of that is you can control the sound on the simulation mannequin, and got a really good stethoscope, put a barrier on it, and had the patient or had the doctor listen, and they got 100% of the murmurs correct. Didn't miss any. Give them a disposable stethoscope without a barrier, and they missed 10.9%. Now, if you think about that, that's missing 1 out of 10, number needed to harm 10. There's nothing in medicine that should be allowed that has a number needed to harm of 10. And so here we have the barriers that provide aseptic contact. Your patient gets a touch-free auscultation, and it doesn't have any effect. It's acoustically invisible. So the quality stethoscope you have is the quality stethoscope you use, and you don't get Pseudomonas from somebody else's disposable stethoscope. Anyway, all right, next slide if we could. So what we're going to do is, in the time we have left, wrap this up a bit with just some final thoughts on how you'd recommend clinicians prepare for these new stethoscope guidelines. And I'll start off with Francesca and then let you all just sort of go wild. But Francesca, the need for a truly effective solution, but one is keeping with new priorities and sustainability is a challenge. And especially with the antimicrobial stewardship environment we're in and CMS's priorities. How do you see all this working together?
So I think we, as you know, hospital waste is one of the highest contributors to waste, to plastic waste. Mm-hmm. And clearly, we're trying, many institutions are trying to reduce that. And so avoiding plastic toys that would further contribute to the waste and would not help you with diagnostic capacity in all fields, right? It's not only the physician visiting that patient, right. It's respiratory therapists, it's nurses, it's students, it's other people. So everybody who goes in and for a diagnostic purpose, whether it's to adjust a ventilator, whether it's to see if that patient now has cleared their wheezing or whatever, or a really complex cardiac auscultation, we have the ability here to use a little piece of plastic that will not contribute to further waste in a dump, and will last for time. So that is a contribution that I think is very important, and that hospitals and healthcare institutions should really think about on top of all the other advantages we discussed.
Yeah, so it's less medical waste, which is a huge plus. That's expensive to get rid of it.
Yeah.
And I think, we focused in our papers, in our research, we focused at looking how, resistant bacteria would would not traverse this barrier. All right. But the point is that any bacteria, whether it's Staph aureus, methicillin sensitive Staph aureus, I don't want to give that flora, that microbiome, that patient to another patient, right? Because that's not their microbiome. So there's also that concept of not further contributing to change the microbiome of patients.
Yeah, I tell everybody I talk to about this that I apologize, that I'm going to change your relationship with your doctor, because the next time they come to you and get that stethoscope, you're going to go, oh, where's that been? Did you wash it for 60 seconds? You know, and you will not be able to forget this. It's in your brain.
Well, Frank, this is Kathleen. One of the very important components is really getting this to the leadership in clinics, in acute care institutions, and making comparisons to other things that we've done to reduce the bacterial burden in the environment to ultimately impact HAIs. And there are so many examples, like Francesca talked about, in terms of the hand hygiene, in terms of the caps on the IVs. And so there's a lot of historical changes that have occurred. And now that this is put into a different category in the guidelines, from a non-critical item to transmission via touch, you've got a much stronger platform to make the comparison to all the other things we've done to reduce the bacterial burden in our environments.
Yeah, I mean, one of the things that we're starting to see is when the Joint Commission comes and pops into your hospital and says, hey, what's your stethoscope hygiene protocol? And people stand there going, well, we better get one. So that's where we are now with these new guidelines, is you better get one because it's coming.
Well, Frank, this is Alpesh. Well, there's a couple things just to build on the comments that were just recently made. On your comment on the Joint Commission, it's not just having a protocol, right? It's actually being able to assess that you're being compliant to that protocol.
Thank you. Yeah.
And so that is a really important step. And right now, the current practice, we are not able to show that we're compliant to the protocol. If the protocol is, every member of the healthcare team needs to clean their stethoscope with an alcohol swab or whatever mechanism, the literature is very clear that that's just not happening. And so there has to be a different method. The other thing, just really quickly, I don't think we should forget about the power of the patient's perception and observation of the healthcare team. COVID, we just came out of a pandemic, and I think there has been heightened awareness around for patients to make sure that their healthcare providers are holding the stature of infection prevention and control. And what you saw in Stuart's clip there was a phenomenal image, right? Where he comes in, he puts a stethoscope under a machine, out pops a patch, and then he uses that in a matter of 10 seconds, everything is done. And that can be protocolized, but that observation is huge for patient satisfaction and patient confidence, if you like, in the healthcare delivery model that we're going after. So these things are really, really important.
Hey, Frank, I'd like to make a couple comments too.
All right, we got a good
Number one is talking about the patient is critical, because patients actually and patients' perception is part of the reimbursement process for most hospitals. And having been a patient safety officer and having directed quality improvement for the state of Hawaii, I can tell you that gets people's attention, and patients really do have a lot more impact nowadays. Some of the things that we've learned with hand washing is having the patient be aware that we are washing our hands for your safety.
Right.
Those kinds of practices go a long way to instituting changes that need to happen. In addition to that, the liability and with patient safety from hospital-acquired infections is huge. And it doesn't just fit into the financial piece. Every single example of this has to be reviewed by the patient safety officer, but it also goes into the liability in the legal department as well as the media. And you don't want to have those kind of really negative perceptions of your facility. So as Kathleen was mentioning, getting this to the leadership is huge. You have the guidelines moving in step. At this point, you have the technology to allow for it. It's a simplified process that allows for every practitioner to do it as they would like to do, because practitioners don't go into practice to harm people. They want to do it right, but it has to be put into a process that makes it easy.
Well, that's pretty much sums it up. Unfortunately, I see Steve waving your hand, but we're going to have to call this officially over. We've used our 30 minutes of allotted time. However, and I'd like to thank our speakers because this is probably the expert board in the whole globe for stethoscope hygiene right here. This group has published more and contributed more than almost any group of people on the planet. So thank you all for being part of this. For the people watching this, thank you. And if you'd like to learn any more about this, then you go to stethoscope.com, and that will be where you can find more information. We're going to stay and hang out for a little bit here. Anybody who has the time and desire to continue listening or talking or asking questions, that's all on the table. And we'll do this until people get tired of it. So Francesca has typed in there, you can also monitor use by month of each disc cover system. And that is the quality improvement strategy for this, is that you could then use this as a quality monitor system. It's not just a delivery of a sterile device, of an aseptic device, but it allows you to have the ability, when the Joint Commission comes to find out what you're doing, you can say, this is what we're doing. And by the way, this is the amount of patient aseptic contacts that are occurring that we're tracking, because we can. That's never been available before. And what'll be interesting is the outcome trials that come downstream from this as systems take it on. So if Steve, I thought you had a question or a comment you wanted to make. If you wanted to go ahead, feel free.
I do. I wanted to return to what Kathleen said. You know that every year in the United States, 200,000 people graduate with one of these things in their hand. That means in 5 years, we'll either have 1 million modern stethoscope hygiene practitioners, or we'll have 1 million people from the last century that we have to retrain in the workplace. So I surveyed educators and managers around the country, and I found out they all agree with us, but less than 10% even have a policy or procedure. So what I think we need to do is create some powerful implementation kits and get it out to the educators and managers to make it easy for them to do this. Because like Kathleen said, people will do the right thing if we make it easy.
Absolutely. All right, so we're starting to get some comments and questions on the in the chat over here, and I'll just burn through a few of them real quickly because they're pretty straightforward. First one is, how does your price point compare to the cost of a disposable stethoscope? Disposable stethoscope, if you buy them by a box of 1,000, cost you about $3.50. And how long do they last? One patient contact and a patient you discharge from the emergency department. So 4 hours, maybe longer, and a patient who stays not in the ICU for a while. But the point being is that's their acquisition cost. The disc cover is the dispenser itself is free. It goes on the wall, and then you get a cassette that holds 420 disc covers inside of it, and that they come out at pennies each. You'll have to ask the sponsor the exact how many that is, but this is nothing compared to the disposable stethoscopes cost, because they're an order of magnitude larger. Somebody said they missed the first 5 minutes of the seminar. Can we talk about the actual new guidelines? So this is the draft. It is what has been put out for public comment, and the final iteration will be released when the CDC feels like it's time. We don't control that, but my experience with these is it's very unusual to be major changes. There will be word twiddles, but we can be pretty much assured that the concept of infection transmission by touch is in the guidelines, and what you do with that is now going to be up to you and your hospital, and how you manage that will affect your patient's outcomes. Where could we find these? That's a Stethoscope is the company that sponsored this, and they will be glad to talk to you. They're on the internet, just like everything is on the internet nowadays. So and the next question is, any studies showing decreased health HAIs when these are in place? And the answer is no, there are not, because to do that, the problem with hospital-acquired infections is there's 1,000 sources. There's the wife who comes in and visits the patient. There is the meal that comes and gets set next to them. There's all that traffic that's going in and out. And so to get that kind of background noise weeded out of a trial is going to take 100,000 patients followed for a year. And that hadn't happened. I have a grant in right now. We're submitting it to the CDC for that exact purpose. But it's going to be a multi-year experiment because of the numbers involved to get the background noise. But I would point out to this, the hand hygiene business, there's not a whole lot of great data on how that worked until Ignaz Semmelweis did it. And that was because, in the 1800s was, in the puerperal fever era, that doesn't exist anymore. So we don't have that opportunity. But it's not a hard leap of faith to think, and all I ask you is, I just saw this COVID patient and I got my stethoscope. Can I come rub it on you? And if you say yes, then you don't, then fine, do it. Most people are offended by that. And so the idea that I need a study to make it okay to rub infected stethoscopes on you is somewhat a stretch, because, you go to the salad bar and they have this thing over it. And if anybody coughs on the salad bar, everybody goes, woo, and they take it away and put in a new one. People understand how pathogens are spread, and this is really not much different. All right. Is anybody of our veritable crowd here?
There was another question.
Go ahead.
Oh, I would just like to comment to Joyce. My program in Honolulu, a Stethoscope was happy to set us up because, every student that graduates knows how to use it. They really took care of us. So I think they're pretty education friendly.
So if you have access to the comments, you can see there, the Stethoscope has put up the Discover system at www.discover.com, where you can learn more about the Discover system. Oh, and somebody here has asked, what about cleaning a stethoscope tubing? This is one of my favorite questions.
Oh, yeah.
Because, there are bugs on the stethoscope tube. There are bugs on your elbow. I don't wash my elbows when I go see a patient because I don't rub them on the patient. And the tube does not rub on the patient. So, you could clean everything. At some point, you have to go where the money is. For the hands, it's the fingertips. And if you look at fingertip cultures, they're really high on humans. Not so high on the backs of the hands. Not high at all on the wrist. And so once you get to the wrist, we quit washing because it's just not necessary. Once you get past the diaphragm, you could do more, but it doesn't, what I call the juice to squeeze ratio. A lot of work, no, not much benefit. So the idea is to not sterilize the entire human, but sterilize the points of contact. So the hands and the stethoscope diaphragm. All righty. We're about 10 minutes after the hour. And I think I'm out of questions. Anybody from the board want to make a final comment?
Frank,
Right.
the only comment, the quick comment I would make is that when we think about the triple aim or the quadruple aim, this technology actually meets that extremely well, because when we're talking about quality and patient experience and reduction of cost and coworker satisfaction, all of these things are well accomplished by a really good barrier system like Discover to embrace the importance of getting rid of stethoscope hygiene problems, right? And so if we believe in the triple quadruple aim, this is something that achieves it in every aspect.
Okay, Alpesh, I think you have to define those aims for everybody who's not familiar with them.
Yeah, so the triple aim obviously is patient experience and quality are two of the aims, and reduction of cost or resources is the third aim. So improving quality, improving experience, and reducing cost. And then the fourth aim, if you want, is coworker satisfaction, if you like. And so all four of those are well achieved by this process.
Mm-hmm.
And what an excellent way to end our board. I'd like to thank everybody who participated today. I'd like to thank all the attendees, and I hope that we can push this needle further along with the release of the new guidelines. Thank you much.
Thank you, Frank.
Thank you.
Thanks.
Thank you. Goodbye.